Good afternoon and welcome to our Cardiac and Vascular Lecture Series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Mario Pascual, who will be presenting a lecture titled The Rapidly Evolving Field of Electrophysiology. Dr. Pascual is a medical director of the Electrophysiology Service line at Miami Cardiac and Vascular Institute at Baptist Health, South Florida. He's a board certified in internal medicine, cardiovascular medicine, and clinical cardiac electrophysiology. Dr. Pascual received his medical degree from the University of Miami Miller School of Medicine. He completed his residency in internal medicine at University of Miami Jackson Memorial Hospital, followed by a fellowship in cardiovascular diseases at the Ochsner Clinical Foundation Heart and Vascular Institute in New Orleans, Louisiana, where he was named Chief Cardiology Fellow. Additionally, Dr. Pascual completed a fellowship in clinical cardiac electrophysiology at the University of Florida in Gainesville. Dr. Pascual honors include the Herman L. Price MD Clinical Excellence and Heart Failure Award and the Edward Ganton and the Clinical Excellence in Cardiology Award from the Ochsner Clinical Foundation. He was also named the Chief Cardiology Fellow by the Ochsner Clinical Foundation. Dr. Pascual has published in medical journals and lectured at national and international conferences on issues related to his field of specialization. In addition, he has conducted several clinical research studies to improve the efficiency of treatments such as cardiac resynchronization therapies. Please, let's give a warm welcome to Dr. Mario Pascual. Dr. Pascual, thank you so much for accepting our invitation. Welcome.
Dr. Kim, thank you very much. Thank you for giving me some time to talk about my field, something that I'm really passionate about. So I appreciate the time.
Of course. Go ahead and share your presentation if you can, Doctor.
Okay. Okay. Able to see the screen well?
Perfect.
Thank you. Thank you for taking some time to spend with me today. We're going to talk about the rapidly evolving field of electrophysiology, and I thought specifically we would discuss VT ablations, as we've had some pretty exciting opportunities. So, I think in electrophysiology over the last 5 years, there have been significant technological and intellectual advancements in the field of EP. And really the success rates for our ablation procedures have never been higher. They've never been safer. We've never been more efficient in the lab and cut down procedure time. And our device-based therapy for heart failure continues to reduce mortality and decrease symptomatology. And I may be biased here, but in my opinion, this is one of the reasons that EP is the most exciting field of medicine, just how rapid things are advancing. But despite these advances, we continue to have limited access to EP procedures. If you see the number of patients in the United States and across the world that are diagnosed with arrhythmias and then treated with certain procedures that can be curative or at least really decrease the burden of arrhythmias, you can see that there's a big discrepancy. So a large lag between our procedural success rates and our ability to educate our referring physicians, our patients, and really anybody in the field who could really benefit from our procedural successes. So education, I think, is a personal endeavor of mine, certainly a personal endeavor of our service line, and it's something that we're passionate about. So we really thank you for giving us and spending some time with us. I think when Miami Cardiac and Vascular Institute was started, many years ago now, the philosophy was always to use a team-based approach to patient care. And I think now more than ever, we've realized that, back 20 years ago, 25 years ago, MCVI was really thinking way ahead of the curve, because now in 2021, it is clear that you can no longer practice in silos in medicine, and especially in the cardiac and vascular space. We use a multidisciplinary approach, which has been proven to improve patient outcomes, improve patient access, and truly fosters innovative approaches to the treatment of medical issues. And so at the Miami Cardiac and Vascular Institute, something that we'll talk about and we'll go over a case presentation very soon, is we performed our first radioablation for incessant ventricular tachycardia at Miami and Cardiac and Vascular Institute. And we're really one of the only centers in the country and truly in the world, and certainly the first in Florida to have done this, using radiation therapy to treat the cause of ventricular tachycardia in a patient. And we'll review the case in detail in just a bit, but highlighting the multidisciplinary approach to treatment of arrhythmias. So let's talk a little bit about ventricular tachycardia. This is a ventricular arrhythmia. That's the major cause of sudden cardiac death, causes about 4.2 million deaths per year. We certainly have multiple therapies that exist for patients with arrhythmias, including antiarrhythmic drugs, implantation of defibrillators, not so much to prevent arrhythmias, but more so to treat them, as well as ablations in order to get rid of the arrhythmic substrate. And one of the ablations is called radiofrequency ablation. When we talk ventricular arrhythmia ablation, there's truly a wide range of ventricular arrhythmias. And the treatment is really going to depend on the prognosis. The prognosis of ventricular arrhythmias can be quite benign, something such as outflow tract PVCs, or they can really be life-threatening. And one of the main kind of differentiators of if ventricular tachycardia is going to be life-threatening or benign is going to be the absence or presence of structural heart disease. So the first thing we look at when we talk of ventricular arrhythmias is, does this patient have structural heart disease, that meaning underlying coronary artery disease or a heart attack in the past? Or does he have some type of cardiomyopathy or weakening of the heart muscle that can contribute to that ventricular arrhythmia? Or is there absence of structural heart disease? Does he have no heart disease whatsoever? And that usually can separate those arrhythmias from life-threatening and benign. Just like everything in medicine, it's certainly not absolute, but it's a good guidance as to where we're coming from. When we talk ventricular tachycardia in the presence of some type of structural heart disease, so again, history of heart attacks, weakening heart muscles, or dilated cardiomyopathy, these are usually the patients that we worry about because these arrhythmias are usually life-threatening. These patients are usually very symptomatic with recurrent ICD shocks if they have an ICD in place, which if you talk to any patient that has had an ICD shock, they will all tell you the same thing. It is extremely unpleasant and painful. So something we don't want our patients to receive are ICD shocks. They're unpleasant, they're painful, and they really interfere with quality of life. They're doing a very important purpose. They're resuscitating the patient and assuring that there's no death, but we don't want our patients to get shocked because it's very uncomfortable. So if we have a patient with ICD shocks, this is where VT ablation will come into effect. And VT ablation is a class 1 indication for symptomatic drug refractory ventricular tachycardia. So the question often comes up if you have a patient on medical therapy with a defibrillator and they are getting ICD shocks, should we just add some medications and watch those patients, what we call escalate therapy, or should we do what's called an ablation procedure, which we'll talk about in a second? And before we talk specifics, this was a trial that came out in the New England Journal of Medicine in 2016 that showed in those patients that have an ICD and are on therapy, as opposed to escalating therapy, if we proceed for ablation or some type of procedure intervention, the incidence of the primary outcome, which was death, ventricular tachycardia storm, or ICD shocks, was significantly decreased in those patients who underwent an ablation procedure, as opposed to those patients that had an escalation just of medical therapy. And that was predominantly driven by decreased incidence of recurrence of ventricular tachycardia here after the ablation, as well as reduced incidence of appropriate ICD shocks. So when we talk VT or traditional VT ablations, what we first do, and I'll show you them in a second, is create a map of the left ventricle. So we're actually putting catheters within the left ventricle of the heart in order to understand how healthy or unhealthy is the left ventricle or the right ventricle of the patient, to understand where this arrhythmia is propagating or coming from. We use a separate catheter that has a small tip, usually 3.5 millimeters, and that catheter delivers tissue or heat energy into the ventricle in order to get rid of the area where this abnormal tissue and this abnormal rhythms are coming from. But of course, the heart is not a very smooth structure, and we have to maneuver around obstacles, and the heart continues to move. We don't arrest the heart while we're ablating. The heart continues to beat anywhere from 60, or if they're in ventricular tachycardia, 160, 170, 180 beats per minute. And catheter stability is critical to success. So if we can't get that small tip catheter and put it exactly where we want it to be, and can't have it be stable there, our VT ablation will not be successful. And that's where the EP kind of field continues to progress, and our technology understanding of arrhythmias continues to progress, to have more stable catheters and technology to allow us to maneuver and assure we have good contact. And the first thing I'll show you is what we call ultrasound maps. So similar to an echocardiogram where we put an ultrasound in the patient's chest, what we do here is we do what's called intracardiac ultrasound. So we're actually getting an ultrasound catheter that's quite small. It's a 9 French sheath, so about 8 centimeters. We're putting that catheter within the heart, and that catheter then gets images of the heart. And I want you to look here inside the heart. The heart has an inside, or what we call the endocardium. It has a middle, or a muscle, and it has an outside, what we call the epicardium. And these ventricular tachycardias can come from anywhere within these areas. It can come from the endocardium, the mid-myocardium, or the epicardium. This here is what we call the papillary muscle. So you can see here the papillary muscle attaching to the chordate of the mitral valve, another obstacle to maneuver your catheter around. And so we use this ultrasound to get a picture of the heart slice by slice, so we can understand not only where the inside of the heart is, but we can look at where the papillary muscles are, and we can look at where the outside of the heart, understanding how thick or thin the tissue is there. And if we continue to get different slices of the heart, we can eventually create a 3-dimensional structure of the heart. And this whole process takes probably about 7 minutes to do. So we can have a very good understanding of what this patient's left ventricle looks like, and we haven't even yet put a catheter within the left ventricle. Okay, not only understanding what the left ventricle looks like, but also understanding the obstacles we're going to have to go around. The next part of that procedure will be putting that catheter within the heart and creating these very beautiful abstract pictures, this abstract art, okay? And this catheter, we've put it into the heart, and what these colors are showing us are how healthy or unhealthy the heart is. And we've created this picture of the heart, and I want you to think about a football. This would be the top part of the football, so the top part of the heart. This would be the lateral aspect of the heart, or the lateral wall. This would be the septal wall, and this would be the apex here. Purple on this map means nice, normal, healthy tissue. Red means dead. Dead meaning scar tissue. So you can see the amount of scar tissue this patient has developed within the heart at the apex of the heart. And if I go to the next slide here, this is kind of the septal. So the septal aspect of the heart, as well as the inferior wall of the heart. So the bottom wall of the heart, the apex, and the septum have all suffered significant damage. So significant heart attack that has affected that area of the heart. And so you can imagine this large area of scar. We have a 3-millimeter catheter, and we're just going around the heart, ablating, that's what these red dots are, with a small catheter going in and burning all the areas of abnormal tissue conduction. And in this video, I'll show you exactly what we do. This is the aorta. The catheter is going around the aorta. You can see the catheter is going through the aorta, now pointing directly down towards the bottom part of that football, or that inferior wall. This blue thing here is what I showed you earlier, the papillary muscle, okay? So we're using our ultrasound catheter here, and I can show you that again. To show you exactly, you can see here with the little green, where that catheter is within the heart, how the heart is bouncing up and down, up and down. You can see that movement within the catheters. So our mapping system, and there's the tip again, mapping system allowing us to show exactly where the catheter is if our catheter is stable or not, and where our force is pointing. So we're pointing directly down, directly where we want our catheter to be. And catheter stability is great. We're delivering a very good lesion, but towards the end of it, you can see the catheter kind of just slips out of the heart. So not good catheter stability, giving us an understanding of how well or how poorly the area of ablation was at that spot. And so at the conclusion of the case, this was our map. All the abnormal areas of conduction were ablated or gotten rid of. But you can see that there's a lot more red tissue, a lot more dead tissue. And luckily, there was no further arrhythmias from anywhere else within the heart, but that's certainly a possibility in the future. And that's why when we talk VT ablation, we can decrease the incidence of recurrent ICD shocks by about 70%, but about 20% of patients will need a second ablation at some point. But we can significantly reduce the incidence of recurrent VT. We can significantly reduce the incidence of recurrent ICD shocks, and that's always our number one goal. These VT ablations generally in our institution are done with general anesthesia, sometimes done with moderate sedation. These are usually patients, again, with structural heart disease, so they tend to have poor heart function. And we tend to sometimes have to use mechanical heart support because their blood pressures can drop. So can be complex ablations and can sometimes lead to some consequences such as ICU stays. So at MCVI, when we were presented with this patient, and we'll go step by step into exactly what our thought process was, this is where that multidisciplinary approach became very handy for us. Okay, so this was a 77-year-old gentleman, an ischemic cardiomyopathy. His ejection fraction was 10%. He had had a CABG and mitral valve repair in 2004 with a redo CABG in 2020, mitral valve replacement, tricuspid valve repair, a traditional kind of ablation or VT ablation in the past with a cryoablation, which we'll talk specifics in a second, with a biventricular ICD. And despite alternative therapy, use of 3 medicines, amiodarone, mexiletine, and propranolol, he continued to show up to the emergency room with what we call VT storm, meaning kind of incessant ventricular tachycardia for over 24 hours. So in April of 2020, he presented to our institution with palpitations and lightheadedness. I'll show you the EKG in a second, but it was consistent with ventricular tachycardia. The ventricular tachycardia was pace terminated, which means we use his own defibrillator to just pace him out instead of having to shock him. He was started on amiodarone. The echo at that time didn't look too bad. Normal ejection fraction of 65%. He was found to have a large aneurysm, which I'll show you a nice picture of a little bit later. But unfortunately, from that mitral valve repair in 2004, was now found to have, once again, severe mitral regurgitation. This was the EKG on presentation. So when I look at this EKG, I see a very wide complex tachycardia that doesn't look like a typical right bundle or left bundle. And I can tell you that there is some VA dissociation on this EKG consistent with ventricular tachycardia. So certainly a dangerous rhythm. We know this is a patient that has coronary artery disease status post-CABG, so he has structural heart disease. So this is a ventricular tachycardia that can be, and it was life-threatening. We worry about this patient, and he's found to have severe mitral regurgitation. So in May of 2020, he underwent redo CABG. He underwent now a mitral valve replacement. He had a tricuspid valve repair, and because of that history of ventricular tachycardia, during the operation, we did a VT ablation. And instead of getting that small catheter and delivering heat energy to the areas, we got a big clamp and kind of clamped that aneurysm and just kind of burned around the aneurysm from the outside. So remember, the heart has an inside, the endocardium, has a middle, the mid-myocardium, and has an outside, the epicardium. So we clamped from the outside and burned all around the aneurysm, hoping that we were able to ablate across the entire thickness of the heart tissue. He had a prolonged hospital stay. The recovery from that surgery, it was a pretty extensive surgery, was about 3 weeks, so hospitalized for about 3 weeks post, but kind of recovered pretty well. But unfortunately, in September, presented with a 2-week history of increasing dyspnea and exertion, significant weight gain. And now we noted a significant change in his echocardiogram. Instead of a normal ejection fraction, his ejection fraction had now dropped to 25%. His heart had severely dilated, and he was again found to have that aneurysm, which was ablated but not cut off or anything, so it's still there. But at this time, he also had severely dilated right ventricle. So instead of a normal heart, now he has a failing left ventricle as he has a failing right ventricle. His tachycardia, he had recurrent ventricular tachycardia, which required an ICD shock. And at this point, he only had a single chamber ICD. And so at that time, we optimized his medicines. So he was started on beta blockers. He was started on Entresto, an MRA, digoxin, an SGLT2 inhibitor, which is now approved for heart failure, and was placed and loaded on amiodarone. Because he only had one lead and was pacing from the right ventricular lead, these patients can develop what we call dysynchrony. So if you're only pacing on the right side of the heart and not the left side of the heart, so if you only have one lead and not two, your activation and your pacing comes from the right ventricle to the left. So, and if you're only pacing from the right ventricle to the left, you develop what's called dysynchrony. Your ventricle is not squeezing or activating at the same time. So what we did is we added an additional left ventricular lead. So now we can have synchronous activation of the right ventricle and the left ventricle. So you have a failing LV, a failing RV. We were hopeful that by upgrading him to a biventricular ICD, we can improve his ejection fraction. And by proving the ejection fraction, his ventricular tachycardia would only improve. But unfortunately, in December, he presented with recurrent palpitations and lightheadedness. He was found once again to be in this EKG. Once again, what we call a very wide complex tachycardia, which has a right bundle morphology, suspicious for coming from the left side. And based on our EP evaluation of this EKG, this is once again coming from that aneurysm that we have already tried to ablate a couple of times, twice. VT was ablated, and now his EF is once again 10 to 15%. So a very sick patient. So now he comes with recurrent VT storm. He was already on amiodarone and propranolol. We added mexilotine, again, because of the severity of his sickness and his low ejection fraction. And we kind of had a discussion with the family. He had just had a large surgery, he had a tough recovery. His heart function was only getting worse at this time. And we thought he was a very high risk for a traditional VT ablation, which already had been offered twice to him. And so we knew that this was somebody that we had to offer an alternative solution. Okay, so we offered him cardiac radiosurgery. But once we offer cardiac radiosurgery, it's not just offer cardiac radiosurgery and go straight to surgery. This requires a very comprehensive or multidisciplinary approach. So he was evaluated by our general cardiologist, our EP cardiologist, our heart failure specialist, and we have cardiac imaging specialists. Our pre-treatment assessment was done by a radiologist, radiation oncologist, who have been extremely helpful in the treatment of these patients, our medical physicists, our dosimetrists, and then we established multiple imaging to establish our kind of target for treatment. And so if you look at our treatment plan, we create these 3D maps, which we had shown you earlier. We obtain a CT imaging, and we integrate the CT image with our electron-anatomic imaging to really define what we call our target. We delineate our target with the CT scans done at the Miami Cardiac and Vascular Institute. And then the radiation oncologists kind of decide how much energy can be developed or delivered, or radiation can be delivered to that area of the heart to get rid of that abnormal conduction tissue, that abnormal radiation. And the patient then undergoes radiation. And we talked about our traditional VT ablation, which requires general anesthesia. It's usually a 3, 4, 5 hour case, sometimes requiring mechanical support like a balloon pump or an Impella. A lot of times requires an ICU stay. And we're delivering energy little by little within the heart, just one dot by one dot. radioablation instead, when this patient came in, and I told you already how sick he was, we had established a peripheral IV access. He required no sedation, and we were with him the whole time. Procedural time was about 30 minutes, monitored for an additional 20 minutes after the procedure, and he was home for dinner. He did extremely well with no prolonged stay. And so this is what we targeted. We talked about that large kind of basal inferior wall aneurysm. In this CT scan, this is the left ventricle here. And you can see he has this little outpouching, what we call that aneurysm. And so the radiation oncologists, you can see they highlighted this area. They delivered radiation to that area in order to get rid of its ability to conduct electricity and produce that arrhythmia. And we couldn't be more excited to say that we're now 6 months out. He is off of amiodarone. He remains on low-dose mexiletine and beta blockers, but he's had no recurrent ventricular tachycardia. He's had no recurrent hospitalizations. And you can see that his ejection fraction, although it had dropped all the way down to 10%, is now back up to about 45%. So again, kind of single patient experience, but certainly an excellent outcome. And so we believe that cardiac stereotactic radiosurgery is a promising, innovative treatment alternatives for select patients with symptomatic VT, especially those that are not candidates for traditional VT ablation because of the overall severity of their illness. Right now, we know that the toxicity profile is extremely favorable out to 1 year, but we are currently doing studies looking at the long-term benefit and long-term toxicities out to 5 years. And so we certainly await results of ongoing clinical trials, and we continue to treat select patients on a case-by-case basis. But we have had excellent outcomes, just highlighting the multidisciplinary approach. If you want to shift focus a little bit to now ventricular ablation in the absence of structural heart disease. So we talked about doing VT ablations in the presence of structural heart disease. Now we'll kind of switch a little bit more to the more benign, but still highly symptomatic arrhythmias, which can affect our patients. And in the absence of structural heart disease, the most common PVC or VT will be what we call outflow tract PVCs. These are idiopathic PVCs or premature ventricular complexes that arise from specific areas in the heart. As we know, we have a right side or a right ventricle, and we have a left side or a left ventricle. And the right side will have an outflow tract or a tube-like structure that evacuates or sends blood out to the lungs through the pulmonary artery. The left side of the heart will have an outflow tract that sends blood from the left ventricular outflow tract to the brain and kidneys. This area here is what we call the outflow tract of the heart, because it is exiting to the lungs or exiting to the systemic circulation. And based on certain EKG criteria, we can identify where these patients have outflow tract PVCs. These are usually seen in younger patient population in the 3rd and 4th decade of life, and they can be highly symptomatic, causing palpitations, syncope, loss of consciousness, near syncope, and importantly, they can lead to a tachy-mediated cardiomyopathy or heart failure. So if you have a high burden of PVCs, which we define anything above 10%, these patients are at risk to develop a cardiomyopathy from their PVCs, and it's completely reversible. And that's why we like to really, educate patients, physicians, referring physicians about the importance of monitoring and diagnosing outflow tract PVCs, because they can certainly have consequences, especially in the young patient population. And so recent advancements to help us ablate PVCs and reverse that cardiomyopathy or help those symptoms that can really be bothersome are integration of cardiac imaging and the addition of their ultrasound maps, which we saw earlier today. So again, really defining cardiac structures and catheter locations has never been better in electrophysiology. And we'll show a couple of examples now. So this is a CT image or CT integration that we obtained prior to our ablation to really show us the aorta. We can then define our right coronary cusp, RCC, our left coronary cusp, and our non-coronary cusp. And in this patient, we've put in that ICE catheter or ultrasound catheter within the heart. We're looking towards the coronary cusp, and we have the CT image that we can integrate and then get the live image in the lab of the left coronary cusp, right coronary cusp, and non-coronary cusp. And now we can have an excellent correlation between our left coronary cusp and our left main coronary artery, our right coronary artery. Because when we ablate in this area, we want to be able to eliminate the PVC, but we want to avoid very important structures such as the left main coronary artery and assure that we're at a safe enough distance from it. So at this point, what we've done is, again, integrate our CT image. We've brought our ablation catheter around the aorta, which we'll see in a couple of slides, and we put our catheter within the heart. And as the patient is having PVCs, we want to assure that we are within the area of the heart where these PVCs are coming from. And once again, we start to make these abstract colors. And when we do what we call our activation map, means that we're putting our catheter in the heart, and once the PVC is activated, we are trying to see how close or how far we are from the earliest source of that activity. So we want to find the cell or cluster of cells that are triggering or causing that PVC. And if we can get to that location in a safe manner with good catheter stability, we can burn that area and eliminate that PVC. In this case, we can see on this right side here, red is early, and yellow is a little bit later, green is later, blue is later, and purple is very late. So in this area here, we have found our earliest spot. So this is where the PVC is coming from. It is coming from what we call the left coronary cusp. So he's had abnormal conduction of electricity, abnormal we call automaticity, arising from the left coronary cusp. Integrating our CT scan, our activation map, and our ultrasound map, it doesn't display very well, but ever so slightly, you can see a little red structure right here. So I can tell you that's where our catheter is, and that's exactly where we burned. We can be 100% sure that our catheter is stable on this spot, that it is sitting within the left coronary cusp, and that it is a very safe distance away from the left main coronary artery, assuring that we're going to ablate in a safe location with very good stability and not anywhere near the left main coronary artery, which can cause significant damage, such as an acute myocardial infarction with occlusion of that vein. And we don't just map the left ventricular outflow tract. This is a map of the right ventricular outflow tract. So this is the pulmonic artery sitting up top. This is the outflow tract. And you can see everywhere within the right side, purple means late. So we were very late in reference to the PVC. And then we were getting earlier as we mapped closer to the coronary cusp. I like this slide also because it shows you the proximity of the left ventricular outflow tract and the right ventricular outflow tract. So as electrophysiologists, we're very interested in the anatomy of the heart. We consider ourselves cardiac anatomists because we really have to understand relationships. And if we map in the right ventricle and we think how early, we think we're early, well, now we map the left ventricle and you can see how close the left coronary cusp and right coronary cusp are to what we call the septal aspect of the right ventricular outflow tract. So you can see its proximity, and understanding and using the CT, the ultrasound, and what we call the activation map, we know exactly where that PVC is from. We ablated within the asterisk. Now, again, it's not just ablating. We have to assure that we deliver a good lesion or an effective lesion. We have to make sure our catheter is stable. So there's a lot going on this slide, and we're going to kind of go step by step into how, as electrophysiologists, we can assure that we're delivering an effective lesion. So I've shown you all the maps before, showing that we're very early there. We've mapped it. This is our target. We've used the ultrasound to assure the catheter is stable there. We've used the ultrasound and the CT to assure that we're a safe distance from the left main coronary artery, which you can see here. And now all we got to do is burn there and burn effectively. But remember, the heart is moving at 60, 70, 80 beats per minute. We've taken our catheter. The catheter is sitting within the left coronary cusp. And now I have this, what we call our directional vector. So I know our catheter is pointing in this direction. Now, it's not enough to just point in some direction. We have to make sure that we're pointing with a certain amount of force to make good contact. So our catheters have a little spring at the end. It's a tiny little minuscule spring. And that spring can detect differences in grams of force. So that spring is detecting that the force is going in this direction, and it is going in that direction with a force of 23 grams. And based on studies, we know that any force between 5 and 20 grams can give you an effective lesion. So I have 23 grams. I'm pointing directly at the cusp. If the direction was pointing this way, not where I want to be burning. I don't want to be burning up. I want to be burning directly towards the cusp. If it's burning this way, so kind of leftward and upward, we're burning towards the left main coronary artery. Definitely don't want to burn in that direction. We want our directional force to be exactly towards the left coronary cusp here, where that abnormal tissue is conducting. If you see these little bars here, that tells us how stable our catheter is. So if our contact is intermittent, so as the heart contracts and then lets go, our catheter is kind of falling off. Only one kind of square bar would be blue. The rest would be black. Here we have 3 out of 3 blue bars with 23 grams of force pointed in the right direction. We know using ultrasound CT integration, as well as what we call our contact force catheters, or that little spring telling us the direction of our of our force with how many grams, that this is going to be a very effective lesion. We delivered 1 lesion in this area and the PVC terminated with very successful results. This is about 1 year out, no recurrence of the PVCs, and this patient had complete resolution of their cardiomyopathy in a very young patient who was very symptomatic from their PVCs. So as opposed to medical therapy for suppression in young people, we can offer them a procedure to eliminate the need for any further workup, and that can, with a very high success rate, eliminate the diagnosis of a cardiomyopathy for these patients. In discussing a cardiomyopathy, I wanted to highlight a little bit the cardiac resynchronization therapy, just because we presented a case of a patient that had the biventricular ICD, which I showed you a chest x-ray of earlier, and kind of highlighting its effect and its success rate in heart failure patients. So, you know, this is one of the most successful heart failure therapies over the last 15 years. And its indication is anybody with a dilated cardiomyopathy with an underlying left bundle branch block. So the ejection fraction less than 35% with an underlying left bundle branch block. This is the addition of a lead in the lateral vein that we put within the coronary sinus. So the heart's kind of, the arterial side of the heart are the coronary arteries. And just like the rest of our body, it has to have a venous blood flow return to the heart. And that venous blood flow is through these lateral veins back into the coronary sinus, which then drains into the right atrium. And so with cardiac resynchronization therapy, we can have a significant improvement in symptoms. We can have decrease in mitral regurgitation, and we can have an improvement in the ejection fraction of the heart. And this is a cardiac resynchronization device. This is an old picture because this was an older lead, but this lead is sitting in the right atrium. This lead is sitting in the right ventricle. And just like I talked about, that the venous return to the heart is through a vein called the coronary sinus. So the coronary sinus is here, and it dumps back into the right atrium to then go into the right ventricle and through the right ventricular outflow tract. So what we do is we put catheters and we engage the coronary sinus and then advance this lead into the lateral portion of the left ventricle. Because when you have a left bundle branch block, your activation is coming from the right ventricle and then kind of depolarizing or activating towards the lateral portion of the left ventricle. So your activation is going in this direction from your septum to your lateral. So your latest point of activation is going to be your lateral, and the heart doesn't like that. The heart likes to beat synchronously, right and left side at the same time. If your right side is beating and then your left side beats, that can cause a cardiomyopathy. So by putting a cardiac resynchronization therapy, our responder rate, meaning improvement in New York Heart Association class, decrease in mitral regurgitation, and significant improvement in ejection fraction, is out to about 50 to 60%. But we are limited by technology because we find a very nice lateral branch. We put that lead within the lateral branch, but then we only have a responder rate of about 50 to 60%. We have to do better. And so that's where the newest technology, which is called multi-point pacing, so pacing from multiple locations within the same lead, has now resulted in improvement in that responder rate. So if you go back to that lead here, you can see it only has one electrode. So our options to pace this lead is only one electrode. In these leads, now we have 4 electrodes, one electrode here, a third and fourth electrode here. And not only is it different 4 electrodes, but they're differently shaped. So you can see the distance between each electrode is different, giving us better options to pace from. So if this electrode doesn't work, well, we got 3 more electrodes that we can see if they work. And instead of simply pacing from one single electrode, we can now pace from this electrode as well as this electrode. By pacing from more electrodes, we activate a larger proportion of the heart. We allow more resynchronization therapy. And now our responder rate, instead of being stuck at 50 to 60%, our responder rate now has improved to 76%, with a more significant rise in ejection fraction compared to our patients with traditional or conventional cardiac resynchronization therapy. So once again, a procedural intervention not only decreases mortality, but makes patients feel better, improves their ejection fraction, and offering improvement in technology to improve our success rates, improve our responder rates. So in summary, I think we can see that electrophysiology is a rapidly advancing field. As an electrophysiology, I'll tell you, it's one of the most challenging parts of our field. There is so much research and so much technology and really new intellectual advancements within electrophysiology that it's tough to keep up. We really have to dedicate ourselves to go to conferences and keep up with our journals in order to understand this new technology. And more, we learned that we can't operate in silos. Electrophysiologists no longer operate in silos. We have the support of our advanced heart failure specialists. We have our support now of our radiation oncologists to offer innovative solutions to patient cares at the Miami Cardiac and Vascular Institute. And I think we've taken up our time there. Once again, thank you very much. And I'll open it to questions at this time.
Thank you so much, Dr. Pascual. What an incredibly insightful presentation. I know that, as you stated at the beginning, these past years have been just revolutionary for electrophysiology, and especially for your area of expertise. I know that some of you have questions directly to Dr. Pascual. I want to remind the rest of the audience to please post your questions directly to the Q&A section in the bottom of your screen, and we will try to address those as we go. So, Dr. Pascual, you mentioned a few important things that I wanted to recapitulate, if I may, and one of which is the new approach of actually managing heart failure and obviously managing arrhythmias and all the different components of the conditions that leads to heart failure. Now, you did mention an interaction with the interdisciplinary team. So you submit these cases to an interdisciplinary team type conference in which a modality is perhaps suggested. The question that I always get to think about is, would the electrophysiologist already predetermine the type of modality that you're going to be using in a specific patient, be it chemical like we used to do it before, or the ablation, be it cryo or thermal or radio? How do you determine exactly the type of modality that you're going to be using for a specific condition?
Sure. Yeah. So every arrhythmia is going to kind of take a different approach. And there are certain patient characteristics and indications that will lead us to determine which approach to use. So our traditional kind of ablation technique has used heat energy. And in patients with certain indications, we know that heat energy will be the most effective and best strategy for those patients. But there are other options such as cryoablation or cold energy, which will kind of be more favorable in certain patient populations. So looking at the overall patient population, understanding the mechanism of this arrhythmia then leads us to determine which is the best treatment modality and which is the best ablation strategy to decrease their burden of the arrhythmia and hopefully offer them a good cure. And using that multidisciplinary approach, for example, using a heart failure specialist, is not so much to determine which is the best ablation strategy, but is to assure that that patient is optimized as best as possible prior to undergo any type of procedural intervention. And if we need some type of mechanical support, we have our heart failure specialist, which will help us manage these patients in the post-op setting.
You did mention the cardio stereotactic radiosurgery. That is perhaps one of the newest things that we tend to hear you talk about. And you also talk about the prevention component for PVCs, for instance. Oftentimes, we find these patients that perhaps it's a little bit too late in the process and in their disease process, rather. I'm wondering if we're doing enough in educating our physicians, our primary care specialists, in identifying the source of arrhythmias or an arrhythmia. What do you think we should actually do? Your message was very to the point. We need to be educated in order to prevent. But what do you think that we should really do in order for us to identify earlier these conditions?
Yeah, I think education will be the key, and early referral as well. If as a primary care physician or as a cardiologist, when I speak to them about when to send that patient to see an electrophysiologist, my message is pretty consistent, and almost always earlier is better. And the reason for that is not necessarily that I think every patient needs an ablation as soon as they're diagnosed with arrhythmia, but I can speak to that patient about when is the right time to have an ablation. If I see a patient and maybe he's had 1 or 2 episodes, they were short-lived and he's not very symptomatic, or he hasn't tried some medications that may be helpful, I can say, great opportunity to discuss when is the right time to have an ablation, so that when he goes and he has a better understanding of the disease process, and if he sees those indicators, such as an increased burden or highly symptoms that are breaking through the medication, he can remember, hey, when I spoke to the electrophysiologist, he told me this is the time to do the ablation because their success rates would never be better than now. As opposed to if we have a patient that hasn't been seen, hasn't been educated as to when is the best time to proceed with the ablation, and we catch them 3, 4, 5 years later, and our success rates, let's say, instead of being 90%, are down to about 40% because of the extent of disease progression that we find the day of the ablation. So there's different types of arrhythmias, there's different types of procedures and medications, but the message is usually the same in terms of when to refer those patients, and earlier is usually better. Again, not because we think patients should rush into procedural interventions, but just to educate the patient and hopefully the referring physicians as to when is the right time to ablate these patients and not let that disease progress enough where we'll have limited options in the future.
Mm. And Dr. Rivas joined the conference a little while ago, and he is greeting you and thanking you for the phenomenal presentation. And as a matter of fact, his question was, do we wait too long to refer or under-refer these types of patients? So
Yeah.
there's Dr. Rivas. Hello, Dr. Rivas.
Hello, doctor. An amazing, amazing presentation. For all of you to know that he is my doctor also. So, but yeah, I thank you, Dr. Hakim. I wanted to, I had to join in late, but I was joined in as an attendee. But I find that sometimes the referral, like you said, sometimes the referral comes in too late, or we wait too long. Many a times an insurance company might come back to Dr. Hakim and I and say, you know, why is this costing so much? But it's by the time that we get the patient, the situation. And then again, you know, when is the best time to refer? I mean, as a general practitioner, I'm seeing a patient, I detect an arrhythmia. Is that the best time right away? Or what is your recommendation on that, doc?
Yeah, again, I would. And again, not necessarily because I think as soon as you're diagnosed with an arrhythmia, you need an ablation. But again, we can talk about, you know, what are those symptoms? When is the right time to ablate? What are the warning signs saying, okay, this is rapid progression of your underlying disease process. This is when we need to jump on it. Or there's certain arrhythmias that, you know, first time events are enough. A lot of times patients with supraventricular tachycardias, we can cure those arrhythmias 99% of the time with a complication rate less than 1%. So young patients with supraventricular tachycardias, I usually tell them, you know, I think ablation is our first line therapy. We can have a very high cure rate with a very low complication rate. So depending on the, you know, on the underlying disease process, on the arrhythmia, but, you know, we can always meet with the patient and not always jump to an ablation. I would say, you know, if I see 20 patients in a day, probably only 4 of them will need an ablation that day. But 16 of them, I can really sit down, educate them, and we can discuss, you know, what medications to take to prevent progression, or when would be the right time to jump into an ablation.
We have a question from the audience, and it says, is there a threshold or limit who can benefit for electrophysiology at the earliest or latest time? Example, if they are in early CHF or they're already in severe CHF.
Sure. Yeah. So, you know, I think we as proceduralists and as any type of physician, you want to do procedures on as healthy patient as you possibly can, because we know the healthier the patient is, the better the outcomes will be. So the earlier that the patient is referred to us and the less severe their heart failure is, usually the better the outcomes are. That doesn't mean that we don't want to tackle complex interventions in patients with advanced heart failure. But of course, our procedural risks and our outcomes usually suffer the more advanced that patient's heart failure is. And like anything in medicine, there are certainly patients that are not candidates for any type of procedural intervention. So the earlier in the disease process we can do a procedure, and the healthier we can get that patient prior to the ablation, always ideal. But we're certainly willing to treat patients with even severe heart failure if that's the right choice for them. Certain patients, of course, we will turn down for surgery because of the risk of the procedure, but, you know, not very common.
Okay. There's a patient in the audience, and it says, I did an EKG in the past. The EKG was normal, but said that I had tachycardia. Would this be the same as ventricular arrhythmias?
Not the same. So tachycardia, so it's important to, you know, address this because there's different definitions. So tachycardia just means, you know, when they studied it, it was a long time ago, and there's a little debate over this. They found that your average heart rate will be somewhere between 60 and 110 beats per minute. As electrophysiologists, we go anywhere from 50 to 110 beats per minute. So by the EKG standards, if your heart rate is above 100 beats per minute, that is the definition of tachycardia. That does not mean that that's an arrhythmia. All that means is that your heart rate is above 100 beats per minute. And there's many different types of tachycardia. There's sinus tachycardia, which is just your native sinus node, what kind of drives your heart rate and as a normal process, beating above 100 beats per minute, which can be perfectly normal. Or there's arrhythmias that can be tachycardic, such as atrial fibrillation with tachycardia. So atrial fibrillation with a heart rate above 100 beats per minute. So tachycardia does not mean ventricular tachycardia. Tachycardia simply means heart rate above 100 beats per minute, and defining what type of tachycardia would be the important part of that EKG.
Dr. Rivas?
Yeah, thank you. And as a follow-up to that, and the question that Dr. Hakim asked, you talk about, tumor boards and all this for cancer. And when it comes to cardiac, I would like to call it like cardiac boards, but the importance of MCVI is underestimated, of having everybody that sees one different part of the situation, and everybody has a vote, right? I apologize, I have construction going on. But, how can you talk a little bit about that, about the importance of having everybody available and how working as a team has improved all of this, number one. And then number two, what's the next frontier? I mean, what is the new Star Trek, or the next?
Yeah, there's amazing technology coming up, and I think it's going to be we're probably 2-3 years away from it. But the multidisciplinary approach, improving patient outcomes, it's clear. Improving patient access. So as before, if you practice in silos, it would be, okay, see the interventional cardiologist one day, in 2 weeks, see the electrophysiologist, in another 2 weeks, see the heart failure specialist. And so now you have a 6-week process before you're actually seeing a multidisciplinary approach to your care. Now, using a multidisciplinary approach, we can have a team meeting, what we call a heart team meeting, where we get together and in one morning, we have all discussed the patient's case and have all decided what is the best treatment plan for that patient. So as opposed to waiting an average of 6 weeks to have a decision on what's the best way to go, in one morning, we sit down, review the case, and we have a plan for that patient. And not only do we have improved patient access and improved efficiency, but we've shown that we can improve patient outcomes, because every specialty is going to look at the case with a different set of eyes and a different level of understanding. And so something that I see as an electrophysiologist, our heart failure specialist will see differently as a heart failure doctor, and our cardiothoracic surgeons will see differently as surgeons. And so everybody can give their input. And a lot of times my eyes are opened as an electrophysiologist by what a surgeon sees or what a heart failure specialist sees. And I can tell you these meetings are very educational, I think, for all.
We have one more question, and it says, in a traditional ablation, how long does a patient needs to stay in the hospital after the procedure?
Sure. This is something that we're very proud of. For the majority of our cases, the patients are discharged on the same day. So if we look at any type of SVT, atrial fibrillation, atrial flutter, even our PVC ablations, the vast majority will be discharged same day. For our more complex ablations, such as our ventricular tachycardia ablations, or patients with AFib and underlying cardiomyopathy or heart failure, we usually watch them one day. But the vast majority of our patients are either discharged the same day or require one day hospital stay for kind of tuning up prior to discharge.
You know what, Dr. Pascual, we can wait for the future. We can wait to hear more of the new accomplishments in electrophysiology. And I know that the sky is the limit when it comes to technology. So it's going to be very exciting for all of you guys. We can keep you here for hours on end because it's a very exciting topic. Dr. Rivas, I think that it is time to close unless you have any comments or any other questions for Dr. Pascual.
No, amazing. Thank you, Dr. Pascual, and thank you to all the guests. And Dr. Hakim, take us home.
Of course. And Dr. Rivas, and on behalf of yourself and the entire team at Baptist Health International, would like to thank you again, Dr. Pascual, for your presentation. To all of you, if you have additional questions about today's presentation or any questions in regards to a particular condition or procedure that you'd like to explore, please feel free to send it to BHIWebinars@baptisthealth.net. We will make sure to forward those questions to Dr. Pascual and get back to you soon. Thank you once again. Hope to see you soon, and please stay safe. Thank you, Dr. Pascual. Dr. Rivas, have a great evening.
Thank you very much.
Thank you, doctors.